Hey everyone, this is a two-parter for total hip arthroplasty or total hip replacement. So this first half, we're going to go through an introduction of anatomy, non-operative treatment, and the surgery itself. And then for the next half, the second half, that will actually be specific rehab protocols and information about that. So when we talk about total hip arthroplasty, that usually means that there's damage to both the acetabulum on the pelvis and the head of the femur. There are definitely situations where they don't replace both, and we'll talk about that. But for most intents and purposes, we're going to say that we're looking at cartilage damage on the pelvis and specifically the acetabulum as well as the head of the femur. So just a little review of the hip itself. When we think about the hip, basically the hip joint has to be very, very stable. It's what's supporting everything above it during standing. And it also provides a lot of support during dynamic activities. So the force that travels through the hip between the pelvis and the lower extremity with walking is about 1.3 times our body weight. But with running, it's about 4.5 times our body weight. So there's a lot of force that's transmitted through the hip at all times. So if you think about how much you weigh and how much force has to be transferred through the hips, obviously that is something you have to think about. So if you can lose weight, decrease pressure on the hips, then obviously that's something that we recommend. We've talked a little bit about osteoarthritis in previous recordings. What I'd like to just kind of review is this idea that hip arthritis, specifically osteoarthritis, tends to be a gradual process that happens over years and years. The patients will often tell you that their symptoms are aggravated with weight bearing. As we talked about, there's a lot of force that's going through the hips with weight bearing. And so things like stairs, and obviously something like running is going to increase the irritability at the hip. Also, patients will oftentimes tell you that at end ranges of that movement, they're noticing their pain. So it's not as much through mid-range, but at end range. And then we also have losses of range of motion. And that's a big, big hallmark of why patients can be diagnosed with hip OA, but also why they end up getting surgery for the OA, including a replacement. So what we tend to see is that patients lose internal rotation of the hip first, and then flexion is also decreased, abduction and extension. So internal rotation tends to be the worst. It tends to happen first, and then we can lose other range of motion as well. As we have talked about before, OA in general, osteoarthritis, is characterized by that loss of cartilage, disruption of the articular surface, so we don't have that smooth cartilage surface any longer. And this will then lead to decreased tolerance to loading. So remember, we like those smooth cartilaginous surfaces to take on the force and allow for smooth movement. And as osteoarthritis starts to occur, we lose that ability to take on force very well, and so we end up with damage not only to the cartilage, but possibly the bone underneath, as well as pain, decreased mobility. So how frequently are we seeing hip osteoarthritis? It tends to occur in patients over the age of 50. There's a lot more hip dysplasia in China than there is in Western states, and I will say that in those patient populations, we are seeing osteoarthritis earlier, so you might be seeing a little bit of that with a younger person developing arthritis and requiring something like a hip replacement at a younger age. But still, I would say the prevalence rates range anywhere from 0.4 to 27% of the population has hip OA, especially at these older ages. We tend to classify it or define it by these specific measurements, This is also something that when doctors are trying to decide if a hip replacement is appropriate, then they're kind of looking at these things as well. So a big one is, again, age, but also reports of morning stiffness that lasts for more than 60 minutes. And so if it's less than 60 minutes, if it's just a couple of minutes, again, these are patients that might have some OA, but it's considered very mild. And so that's not necessarily a reason to have surgery. As I said earlier, they're going to have pain with internal rotation, and they tend to have decreased internal rotation mobility. And I promise you, I've seen a lot of patients who their internal rotation is less than 15 degrees, which maybe seems a little bit crazy, but it's definitely possible with some pretty bad hip OA. Flexion can also be decreased. So in this case, you'll see we say less than 115 degrees of hip flexion. And so they're going to tell you that, again, they're having trouble getting their foot up to put their shoes on and things like that. So this is just an example, a picture of that hip OA. You'll see in this case that there are bone spurs, the joint space is narrowed significantly. You've lost that nice smooth surface. And sometimes, again, some people tend to develop bone where the cartilage used to be, and other people just tend to have cartilage wear away. So in this picture, they definitely have developed that extra bone. In our setting, how can we diagnose hip OA? Generally, they're going to tell you that their symptoms are in the anterior aspect of the hip, medial, and along the groin area. So they're going to say that they have these symptoms that worsen with more weight bearing, with increased activity. And they might have had some previous history of trauma, but it's not always true. And we're going to talk a little bit about hip dysplasia more in some other presentations. So we'll talk about things like femoral acetabular impingement. That's another reason that if they've had something like that at a younger age, they may end up with hip OA at an older age. So again, as we said, they're oftentimes going to tell you that they have morning stiffness, but it's not greater than 60 minutes. So again, these are the ones we're hoping we can look at non-operatively. And if it gets worse, then they're considering surgery. And they may have a limp. They may demonstrate decreased hip extension during gait, especially not spend as long on that leg for weight bearing during gait. And then they also will oftentimes say that they have trouble getting in and out of cars or getting in and out of a low chair. Again, those things require some rotation, especially getting out of a car requires rotation. And then it requires a large amount of power through the hips in a very flexed hip position to get out of a chair. So a low chair. So these are things that they'll oftentimes complain about, which makes you think possibly a hip OA. And so you perform your physical examination, and what you're going to find is that there's likely some decreased mobility in that hip. So you're looking at flexion, extension, internal rotation, and adduction specifically. And these are definitely things that you want to measure because we're hoping you can do non-operative treatment for this patient and you're able to improve their range of motion and therefore their function. You also want to check accessory mobility of the hip. You can use things like Faber and Fader, which we'll talk about a little bit later. And you're going to notice that when you perform these assessment techniques, that they're demonstrating decreased mobility as well as pain. And when you're checking hip musculature, they oftentimes will demonstrate decreased hip extension strength, hip abduction strength, possibly even hip flexion or adduction strength. So we do have guidelines related to non-operative treatment for the hip for physical therapy. So this was a guideline that was written in 2009, and we have since had an update, a revision of this guideline. You'll see here that it is in Chinese through the Chinese Journal of Sports Medicine. So if you want to look up the entire guideline, I would highly recommend it if you're working with this patient population regularly. So I'll just kind of review a couple of things here. So we think of these patients in regarded to a certain pattern. So in non-operative treatment and even post-operative treatment, we discussed the fact that they tend to develop mobility deficit. So that's kind of the pattern that we put them in. So we are going to spend a lot of time on joint mobilization as a rule, as part of our treatment. And we're looking to kind of increase hip strength and mobility at the same time. Oftentimes, aquatic therapy is going to be very, very helpful because we can unload them. So we've talked about that a lot. Aquatic therapy is used a lot with these cartilage problems. It seems like every single one of our presentations we mention aquatic therapy, and it really is helpful to allow for mobility, to allow for synovial fluid to get into the joint, but keep it unloaded so that they're not getting too much pressure through the joint itself. And things like a new step or a bike also allow for that. So the original recommendations from the original guideline, just so you can see this, they give them grades, and so a grade A or a B tend to be stronger grades of recommendations. So they talk about, for interventions, that if we're seeing these patients non-operatively, we want to educate them on changing their activity to decrease pain, as well as decreasing their weight, and finding ways to, again, unload the joints. And they also would consider using assistive devices to do that. So you could use canes or crutches or walkers for that to help, again, decrease pain and improve mobility. Manual therapy is very highly recommended for these patients. And we're going to talk about that a little more with the revision that was done for this guideline in 2017. But even back in 2009, we're recommending manual therapy, and that primarily includes mobilization of the joint to help with increasing mobility and decreasing pain. We also can use flexibility, strengthening, and endurance exercises to help, again, with improving function. So 2017, there was a revision of this guideline. Again, this is for patients with hip OA. We're not talking about patients so much after a hip replacement. But we did an entire guideline revision in 2017. And at that point, we made recommendations for specific types of assessments for these patients. You'll see these recommendations are an A, meaning that we have very strong research to say that using assessment physical performance measures like the 6-minute walk test, the 30-second chair stand test, the stair measure, the timed up and go test or tug, the self-paced walk, the timed single leg stance, the 4-square step test, and the step test all have a lot of good research behind them as being assessment tools that you can use and then reuse for reassessment for outcomes. So it's a great way, I think, to motivate patients as well. These patients who have this hip pain, and we use these things, you'll notice as we talk about this, even after a total hip replacement, they tend to be motivated by having a goal that they can set for something like the 6-minute walk test. So if they do maybe, let's say, 300 meters the first time they do a 6-minute walk, and you say, okay, we're going to retest this in 2 weeks, and we'd love for you to get 400 meters, then it gives them a goal of trying to do this. So you don't have to do all of these physical performance measures, but you'll see that it really is helpful. And it's also helpful because then you can show the Chinese government and anybody else you need to tell, hey, look, I am showing improvement in my patients. It's a really nice, easy way to do that. In terms of physical impairment measures that we should be using during our evaluation and reassessment, the Faber test, as I mentioned earlier, as well as the Scour test, and then measuring the passive range of motion, strength specifically internal rotation, external rotation, flexion, extension, AB and adduction. So those are all things that should be used by you as the clinician, as the trainer, to, again, show initial impairment and then improvement as you continue with your treatment. So you'll see, again, this is an A recommendation as well. In terms of treatment, a recommendation for manual therapy. So the revision was able to give us more specifics on what to do for treatment. And they recommend doing manual therapy, specifically joint mobilization, 1 to 3 times per week for 6 to 12 weeks before you're going to see a huge change. So that's pretty frequently. You want to make sure your patients understand that this is something recommended 1 to 3 times a week for that long of a time, so that they understand that the symptom relief might take a little while, but that's your plan of care. There's also a recommendation for flexibility, strength, and endurance training, and you'll notice that this should be done 1 to 5 times a week for 6 to 12 weeks. Again, 1 to 5 times per week is a huge range. I totally get that. Of course, we would prefer that they did it more frequently, so closer to the 5 times per week. But again, that time frame of 6 to 12 weeks is really important for them to understand. There isn't quite as much good research. You'll see it's a C recommendation for things like functional gait and balance training, but I think we all know that these patients oftentimes have had a history of falls and probably are demonstrating gait that doesn't look very safe or very efficient. And so we can all say that providing them with improved education on how to walk better, as well as providing them with balance activities so that they can feel more confident with their gait, both of those things can be very helpful with this patient population. So again, these are all of our non-operative treatment options. Some of these are going to be very appropriate, such as the flexibility, strengthening, and endurance exercises, the balance exercises, and gait training. Those are all appropriate for our post-operative patients as well. So when do the surgeons decide to do surgery? We talked about that idea of over 60 minutes of tightness or stiffness in the morning is a good one that doctors will use to help decide if surgery is appropriate. They have significant functional impairments. If they have avascular necrosis of the femoral head, which we're not going to talk about, but that's another reason why they may choose to do surgery. And then lastly, what we see, I would say almost the most in China, is fractures of the hip. So hip fractures, this says certain complex fractures. I think we probably see it a lot more than just the really complex fractures of the hip. We see a lot. I mean, I would say the vast majority of our hip replacements at our hospital are because the patient had a fracture and the doctor didn't quite know how to stabilize it without doing a hip replacement. So they do a hip replacement. So that's not necessarily the case in Western countries, but obviously that provides, if that's the history of the patient, that's going to be something you really need to consider as you're doing rehab, because that means that they have a history of falls. And so that needs to be a huge part of your focus of your treatment as you're seeing these patients. So surgical technique, there's 2 different major types of hip replacements that are done: the posterior approach and the anterior approach. I'll be honest with you guys, I haven't seen any anterior approaches in China. So this is something that gets done in the United States and other parts of the world, but it's rare that you're going to see it. If you do see it, though, you're going to be ready for it, because we're going to talk about it. So the posterior approach is definitely the most common. And basically what happens is the hip is dislocated posteriorly. There are several deep hip flexors that sometimes they have to release or cut through and then stitch back up when we're done. The gluteus medius, however, is usually left intact. So your hip abductors should be intact and should work. There's usually a bigger risk of dislocation with this surgery. We are going to actually see a video of this surgery in just a minute, so you'll be able to see what that looks like. But just keep in mind that there are the hip precautions in place for a reason, and it's because we do see dislocations of the posterior approach. But it's an easier approach. It's easier for surgeons to do it. And so they tend to do it much more frequently. Again, that's the only way I've seen hip replacements in China. But if you do see an anterior approach, the hip is actually dislocated anteriorly, which actually allows for much less muscle damage. So they really don't have to go through any muscles if they do it that way, but it is a more difficult approach. It's just technically more difficult, so you don't see it as often. So when we talk about precautions for the hip after a hip replacement, we're focusing on patients who have had a posterior approach. So the movements that are limited after a hip replacement are going to be this way because the patient had a posterior approach. If they have an anterior approach, it's going to change things. But what's nice again about anterior approach, you don't really have as many of the precautions and you're less likely to dislocate. So if you do see any of those, please let us know. It'd be interesting to know which surgeons are doing them and where they're happening. Either way, you want to recognize whether or not the implantation has been cemented or cementless. I've rarely seen cementless in China. Most of the time they're cemented, meaning that when they're putting the rod into the femur to stabilize the head of the femur, they're going to use a cement with the rod. And that really does allow for a little bit more stability as well as earlier weight bearing. If they are doing a cementless approach, so they're not using cement with the what we call femoral stem, then you may have more weight-bearing limitations from the surgeon. You'll see here that sometimes they'll require 4 to 8 weeks of limited weight-bearing to allow for a little bit more stability, allow for that to heal a little bit more. So here's just some pictures of examples of what that looks like. So again, in this case, there's an acetabular component as well as a femoral component. The acetabulum, and we'll see a video on this in just a second, can sometimes be replaced all by itself. Let's say if there was a pelvis fracture, or again, the femoral head could be replaced by itself if the acetabulum is in good shape. So let's watch that video.
A hip replacement procedure involves an operation in which the cup-shaped hip socket, or acetabulum, and head and neck of the thigh bone, or femur, are replaced with prosthetic components. The bones of the hip joint experience wear over time, or become damaged from arthritis, fracture, or other conditions, such as bone death due to loss of blood supply. When the cartilage covering the bone surfaces is damaged, the underlying bone becomes irritated and develops spurs and other irregularities, which can cause pain and loss of motion. Your anesthesiologist will determine whether to use regional or general anesthesia. First, the head and neck of the femur are removed in order to provide access to the acetabulum. Next, the damaged cartilage of the acetabulum is removed, and a metal socket is attached via screws or cement. A spacer, made of plastic, ceramic, or metal, is inserted between the prosthetic ball and socket to allow for smooth gliding motion. The bone of the femur is then hollowed out, and the implant stem is cemented or press-fit into the bone. Finally, a metal or ceramic ball is used to replace the femoral head. While complications associated with hip replacement surgery are generally uncommon, they include infection of the wound or around the prosthesis, and blood clots. In rare cases, the leg may be slightly lengthened or shortened in order to maximize stability. Dislocation, loosening of the joint, or implant wear may occur over the years. You will be advised on which precautions to take to minimize the possibility of a dislocation. A total hip replacement is a major surgery that requires an overnight stay and lengthy recovery period. Recovery from hip replacement surgery typically takes several weeks. Sutures are removed approximately 10 days after surgery. Exercise is critical to your recovery. A progressive walking program may be advised to increase your mobility. In addition, a physical therapist may help you to restore movement and strength. Within 3 to 6 weeks, you should be able to resume normal household activities. While your new hip may feel a little strange at first, this will diminish with time, and most patients experience almost complete relief from pain.
Okay, so we're going to finish up this presentation talking about complications. The video did provide you with a couple of them, and they're kind of listed here as well. So dislocation is definitely the most common complication following surgery for these patients. We're going to talk about the precautions in the beginning of the next video. But just keep in mind that it's kind of dependent on the surgeon. I've worked with a couple of surgeons where they just got a lot more dislocations than other surgeons. So if you're working with one of those surgeons, you've got to be a lot more careful than maybe some of the other surgeons. DVTs, deep vein thrombosis, also a possibility following surgery. We want to keep them as active as we can to prevent the DVTs. Infection, I haven't seen a lot of infection with this surgery. It's not very common. But then the implant mechanical loosening, so that implant being loosened within the femur can definitely happen. And I haven't seen it a lot, but it does happen, especially with those cementless femur rods. So that's where we're going to stop for this presentation. We're going to go through precautions and the rehab specifically itself in the next presentation.